the mitopic sutures. So this is the mitopic suture. This was the mitopic suture. Premature fusion of the mitopic suture can lead to another type of head shape which is known as trigonocephaly. So in trigonocephaly, from the front the head is triangular and then behind the head is normal. So when there is an elongated boat-shaped head, it is known as scaphocephaly or dolichocephaly. When there is a triangular head from the front, it is known as trigonocephaly. So scaphocephaly is boat-shaped head, trigonocephaly is a triangular head. Scaphocephaly or dolichocephaly is the type of craniosynostosis which is because of premature fusion of the sagittal sutures. Trigonocephaly is the type of craniosynostosis which is because of premature fusion of the mitopic sutures. Then there is another type of craniosynostosis which is known as brachycephaly. What is brachycephaly? Brachycephaly is the type of craniosynostosis which is because of premature fusion of both the coronal sutures. So this was the coronal sutures. These were the coronal sutures. So when both the coronal sutures they fuse early, it can lead to the head from the front becoming flat. This type of craniosynostosis is known as brachycephaly. So I'll repeat again. Scaphocephaly is premature fusion of the sagittal sutures. Trigonocephaly is premature fusion of the mitopic sutures. And brachycephaly is premature fusion of both the coronal sutures, not one, both the coronal sutures. Now it can sometimes happen that one side of the coronal suture fuses at normal time, but the other coronal suture fuses prematurely. You are seeing here abnormality in the head shape. Now here what is happening is one coronal suture has fused prematurely, but the other coronal suture has fused on time. What is this type of craniosynostosis called? It is known as anterior plagiocephaly. So what is anterior plagiocephaly? One coronal suture fuses early, the other coronal suture fuses on time. So head from the front will become flattened. But if you have both the coronal sutures fusing early, then it is known as brachycephaly. The whole head from the front will be flattened. Here what has happened is one side of the head has become flattened because one coronal suture has fused early. So what is this condition called? It is known as anterior plagiocephaly. And sometimes what can happen is one lambdoid suture can fuse early. What is it called? It is known as posterior plagiocephaly. One lambdoid suture has fused early, then it is known as a posterior plagiocephaly. So I'll repeat once again the 5 important types of craniosynostosis. There are many more types, but for your exams, I think these are the 5 which are enough. So which are those? I'll just tell once again. Premature fusion of the sagittal sutures is scaphocephaly or dolichocephaly. Premature fusion of the mitopic sutures is trigonocephaly. Head becomes triangular from the front. Premature fusion of both the coronal sutures will lead to the head being flat from the front, which is known as brachycephaly. Premature fusion of one coronal suture, the other coronal suture fusing on time, one coronal suture fusing early will lead to anterior plagiocephaly. And premature fusion of one lambdoid suture, the head from the back will become flattened on one side only. Then it is known as a posterior plagiocephaly. Right? So let me write it here so that you can remember. What are the type of craniosynostosis that you should know? So scaphocephaly. Please don't write it. You have already, I think, written. This is just revision. So scaphocephaly, premature fusion of the sagittal sutures. It is also known as dolichocephaly. Second, trigonocephaly. Premature fusion of the mitopic sutures. then brachycephaly, premature fusion of the both coronal sutures. Then anterior plagiocephaly, premature fusion of one coronal suture. And posterior plagiocephaly, premature fusion of one lambdoid suture. So these are the types of craniosynostosis that you should know. Scaphocephaly number 1, trigonocephaly number 2, brachycephaly number 3, anterior plagiocephaly number 4, and posterior plagiocephaly number 5. Scaphocephaly, premature fusion of the sagittal sutures. Trigonocephaly, premature fusion of the metopic sutures. Brachycephaly, premature fusion of both the coronal sutures. Anterior plagiocephaly, premature fusion of one coronal suture. And posterior plagiocephaly, premature fusion of one lambdoid suture, which is overall the most common type of craniosynostosis that is seen in children. Overall, the most common type of craniosynostosis that is seen in children is scaphocephaly. So which is the most common type overall? It is scaphocephaly. So premature fusion of sagittal sutures, scaphocephaly. Premature fusion of metopic sutures, trigonocephaly. Premature fusion of both coronal sutures is brachycephaly. Premature fusion of one coronal suture is anterior plagiocephaly, and premature fusion of one lambdoid suture is posterior plagiocephaly, which is overall the most common type of craniosynostosis. It is scaphocephaly or dolichocephaly. So this is just a revision that we have already done. Can you name some syndromes which are associated with craniosynostosis? So just remember the name of some syndromes which can be associated with craniosynostosis. The 4 syndromes that you should remember which are associated with craniosynostosis are Cruzen syndrome, Carpenter syndrome, Eppert syndrome, and Pfeiffer syndrome. Just remember their names. So 4 syndromes which are associated with craniosynostosis, where one of the features, craniosynostosis is one of the feature in these syndromes. Cruzen syndrome, Carpenter syndrome, Eppert syndrome, Pfeiffer syndrome. It has been frequently asked in the exams, which of the following is a syndrome associated with craniosynostosis, or which of the following syndromes is not associated with craniosynostosis. So you should know which are associated with craniosynostosis: Cruzen syndrome, Carpenter syndrome, Eppert syndrome, Pfeiffer syndrome. I hope you have all written this. Okay, now let me ask you a question before I move on to the next disorder. Which is overall the most common type of seizures in children? Which is the most common cause of seizures in children? So I hope you have the answer. When I ask this question in my classes, which is the most common type of seizures in children, students start coming with all type of answers. So hypoglycemic seizures, hypocalcemic seizures, hyponatremic seizures. But please remember, seizures associated with fever is the most common reason for seizures to occur in children. What are these type of seizures called? They are known as febrile seizures. So the most common provoked seizures of childhood are febrile seizures. Febrile seizures usually occur at ages of 6 months to 5 years of age. So most common provoked seizures of childhood are febrile seizures, which commonly occur in children between 6 months to 5 years of age. So which is the most common type of seizures of childhood? It is febrile seizures. And febrile seizures commonly occur in children between 6 months to 5 years of age. What's the age group in which febrile seizures commonly occur? It is 6 months to 5 years of age. Now let me write it here. Febrile seizures first thing, most common provoked seizures of childhood. Second, they commonly occur between 6 months to 5 years of age. So when do febrile seizures normally occur? Febrile seizures normally occur between 6 months to 5 years of age. Now there are two ways of classifying a febrile seizure. Febrile seizures can be either a simple febrile seizure or they can be sometimes called as a complex febrile seizure. So there are two ways of classifying febrile seizures, rather one way of classifying febrile seizures. Febrile seizures are classified into simple and complex febrile seizures. The question arises, what is the need for classifying them? Why not say febrile seizures only? The need for classifying them is because complex febrile seizures can later on progress to epilepsies in the future. So I just now told you, febrile seizures usually occur between 6 months to 5 years of age. But there are certain type of febrile seizures which carry the risk of progressing to epilepsies in the future. One of the type of seizures which can progress to epilepsies in the future are complex febrile seizures. So when the mother comes to you, it's very important to know whether this seizure is a simple or a complex febrile seizure, because if it is a simple febrile seizure, it is likely to end on its own by 4 or 5 years of age. But if it is a complex febrile seizure, there are chances that it may progress to epilepsies in the future. So what are the features of a simple febrile seizure? All seizures which are generalized seizures. So ask the mother, when the child was having a seizure, was the child having a seizure in one arm or one leg, or was the child having seizure in both arms and both legs? So it was a generalized tonic-clonic seizures. Both the arms and both the legs were moving. This is likely to be a simple febrile seizure. So first thing, so any seizure which is likely to be a focal seizure, is not a generalized seizure, is likely to be then a complex febrile seizure. Second, ask the mother, how long did the duration of the seizure last? So if the duration of the seizure was less than 15 minutes, it's likely to be a simple febrile seizure. But if the duration of the seizure was more than 15 minutes, it is likely to be a complex febrile seizure. So ask the mother, how long did you see your child seizuring? Mother says, doctor, I saw my child seizuring for around 5 minutes, for around 7 minutes, for around 10 minutes. I will say this is a simple febrile seizure. Mother says, doctor, it has been almost 20 minutes, the child has been seizuring. It is likely to be a complex febrile seizure. If there is a single seizure in the febrile episode, single seizure, then I would say this is a case of a simple febrile seizure. So for example, the child has been having fever for the last 4-5 days. But in these 5 days, the child had seizure only once. This is likely to be a simple febrile seizure. But if the child has multiple seizures in a febrile episode, in the same febrile episode, the child had multiple seizures, then this is likely to be a complex febrile seizure. So simple febrile seizures usually are generalized. Simple febrile seizures, the duration is usually less than 15 minutes. And simple febrile seizures, usually there is only one single seizure which occurs in the 4 to 5 days of febrile episode. For example, the child had a urinary tract infection. So fever was there for 5 days. In those 5 days, the child had seizure only once. This is a simple febrile seizure. Ask the mother, second question, ask the mother, how long did you see your child having seizure? Mother says, doctor, I saw my child having seizure for around just 3, 4 minutes, 5 minutes, 6 minutes, 10 minutes. It was less than 15 minutes seizure. It's a simple febrile seizure. Third, ask the mother, was the seizure occurring all over the body or was it only restricted to one hand or one leg? It was all over the body. It is likely to be a simple febrile seizure. So simple febrile seizures are usually generalized, usually last for less than 15 minutes, and there is only a single seizure in the febrile episode. On the other hand, seizures which are focal, seizures where the duration is more than 15 minutes and where there are multiple seizures occurring in the febrile episode, they are likely to be complex febrile seizures. Why are complex febrile seizures so important? As I told you, complex febrile seizures are important because complex febrile seizures can progress to epilepsies in the future. Apart from these three criteria which are given here, there was one more criteria that was given in the past. I don't think this criteria is now given in Ghai. Apart from these three criteria to differentiate simple from a complex febrile seizure, there was one more criteria. Let me just tell you that criteria, but I think now that criteria is not given in Ghai. What was that fourth criteria? The fourth criteria was after a seizure ended, if there was any neurological defect, after the seizure ended, if there was any neurological defect. So now, for example, the mother said, doctor, my child's seizure has ended, fit has ended. Now there is no fit at all, but one half of the face appears to be asymmetrical, or one arm or one leg of the child is not moving at all. So any neurological defect after a seizure episode, if present, this was a complex febrile seizure. If a neurological defect was not present, it is a simple febrile seizure. So neurological defect, it was not present, it was a simple febrile seizure. Neurological defect, if it was present, it was a complex febrile seizure. So I'll just repeat once again the differences between simple and complex febrile seizures. All seizures which are generalized, all seizures where the duration is less than 15 minutes, all seizures where there is just a single seizure episode throughout 4 to 5 days of fever. And in the past, it was said all seizures where there is no neurological defect, they were considered to be simple febrile seizures. Complex febrile seizures were focal, seizures where the duration is more than 15 minutes, multiple seizures in one febrile episode. So 4 to 5 days of fever, multiple seizures occurred. And in the past, it was written that there was a neurological defect along with fit. So fit ended, one half of the body was not moving. There was a cranial nerve paralysis which appeared. This then is likely to be a complex febrile seizure. So complex febrile seizures can progress. So which febrile seizures can progress to epilepsies? So which febrile seizures can progress to epilepsies? I just now told you one febrile seizure that can definitely progress to epilepsies. Is a complex febrile seizure. Then second, if there is a positive family history of epilepsy, this can also progress to epilepsies in the future. And the third is if the child has a developmental delay. So these are the three conditions in which a febrile seizure may progress to epilepsies in the future. Otherwise, most febrile seizures will end by the age of 5 years. Which are the febrile seizures which may progress to epilepsies? Complex febrile seizures according to the criteria that I mentioned. Then positive family history of epilepsies. So if there is a family in which the child's father or mother had epilepsy, this child who has a febrile seizure may go on to have epilepsies after 5 years of age. And third, whenever a child of febrile seizures come to us, we always take the milestone history from the child, because if the milestones are delayed, then the child is likely to have a progression to epilepsies in the future. So milestones. I hope you have done the milestones yesterday. You revised some milestones. Please revise those milestones which I told you, because they are very important for your exams. The milestones we did day before yesterday. Very important for your exams. So which are the febrile seizures that can progress to epilepsies? I'll repeat. Those febrile seizures which are complex febrile seizures, those febrile seizures which have a positive family history, and those febrile seizures which are associated with a developmental delay. Here, there are chances that the child may have epilepsies in the future. Otherwise, majority of febrile seizures that come to us, we do not need to do any investigation. This is a child who will improve on his own. Most febrile seizures end by 3 to 4 minutes. So you do not need to do anything. No investigation usually is required, except when you suspect meningitis in the child, because a fever and a fit can also be an indication of meningitis. So the next question that will come to my mind is, when should I do a lumbar puncture? A lumbar puncture is a test by which we take out the CSF. We take out the CSF and look for meningitis. So do we need to do any investigations routinely in a febrile seizure? No. But sometimes you may need to do a lumbar puncture to rule out meningitis, usually whenever there is a first episode of febrile seizure. And there are signs and symptoms suggestive of meningitis. So whenever there is a first episode of a febrile seizure, first episode, before this mother says my child never had a fever with a fit, first episode of febrile seizure, and when you are examining the child appears to have, say for example, a positive Karnik sign, the stiffness in the neck is present, there is a positive Brudzinski sign, all of these are signs for meningitis. In those cases, yes, you may like to do a lumbar puncture to rule out a meningitis. Otherwise, if the mother says, doctor, every 5-6 months this child has a fever with a fit, so this is not the first time it is happening, so this appears to be a febrile seizure. Otherwise, no routine investigation is required. Majority of cases when the child will come to us, the seizures have already stopped, so you do not need to give any management also. Otherwise, if the child comes to you and the child is seizuring, you may like to give a diazepam to stop the seizure, like any other seizure which can be stopped by diazepam. The last thing I would like to do is prophylaxis. So if the child has been having seizures regularly, febrile seizures have been happening regularly, then there might be an indication to start either oral diazepam or oral clobazam. For how many days? For about 3 days approximately. That is, the fever normally lasts for around 3 to 4 days. So mother says, doctor, in the past, whenever my child had a fever, the child used to have a fit. So it's a good idea to tell the mother, okay, the next time when your child has a fever for around 3 days, please start this oral diazepam or start oral clobazam in the child. So during that time of fever, that will keep a cover and the child will not have a seizure. So oral diazepam or oral clobazam are used as anti-epileptic agents for prophylaxis against a seizure. Do they need to be given in all children? No. They just need to be given in children in whom the seizures are very, very frequent. And what is the indication? More than equal to 3 episodes in last 6 months, or more than equal to 4 episodes in the last 1 year. So if there have been more than 3 episodes, more than equal to 3 episodes in the last 6 months, or more than equal to 4 episodes in the last 1 year, then you need to give prophylaxis. Otherwise, if there are less than 3 episodes in last 6 months or less than 4 episodes in last 1 year, this is not likely to be a very frequent type of febrile seizure. You do not need to give any prophylaxis. So you have understood, prophylaxis only indicated when the child is having these febrile seizures very frequently. 3 or more than 3 seizures in the last febrile seizures in the last 6 months, 4 or more than 4 febrile seizures in the last 1. So let me quickly repeat febrile seizures and then we'll take a break. Febrile seizures are the most common provoked seizures of childhood, and they commonly occur in children between 6 months to 5 years of age. Febrile seizures are divided into simple and complex febrile seizures. So all seizures which are generalized, all seizures with duration are less than 15 minutes, all seizures where a single seizure in the whole febrile episode, and in the past it was said all seizures which are not associated with a neurological defect, they were simple febrile seizures. Complex febrile seizures were all focal seizures, seizures where the duration was more than 15 minutes and where there were multiple seizures in the febrile episode. Can febrile seizures progress to epilepsies in the future? Yes. Many complex febrile seizures can progress to epilepsies. Many febrile seizures where there is a positive history of epilepsy, or positive family history of epilepsy, there also a seizure can progress to epilepsies. And febrile seizures where there is developmental delay, milestones are delayed, there also seizures can progress to epilepsies. Investigations routinely are not required in a febrile seizure except lumbar puncture, which may be indicated in the first episode of a febrile seizure when there are signs and symptoms which may suggest a meningitis. If there are first episode of a febrile seizure and signs and symptoms on examination suggest possibility of meningitis, do a lumbar puncture, take out CSF for examination, and then you can rule out a meningitis. Otherwise, no other investigations are required. If the child comes in a seizure, you have to obviously stop it by giving an anti-epileptic drug. Prophylaxis to prevent a seizure happening can be given by oral diazepam or oral clobazam and is not routinely given except when the seizures, febrile seizures, are very frequent. And what is the indication? More than equal to 3 episodes in the last 6 months, more than equal to 4 episodes in the last 1 year. In these cases, yes, prophylaxis may be required. Otherwise, routine prophylaxis is not required. So, let us quickly revise. In today's class, pediatric neurology, I started by telling you fontanelles of the brain. I told you there are 6 fontanelles, 1 posterior, 1 anterior, 2 sphenoid, 2 mastoid fontanelles. So remember like this, the first to close is posterior 0 to 3 months, sphenoid 3 to 6 months, 6 to 18 months, anterior 18 to 24 months. So which is the first fontanelle to close? It is the posterior. Which is the last fontanelle to close? It is the anterior. Then I also told you neural tube defects. How are they classified? Craniospinal, cranial, spinal. Craniospinal always open, cranial can be open and closed, spinal can be open and closed. Name of craniospinal neural tube defect, craniorachis, open cranial, anencephaly, closed cranial, encephalocele. Closed spinal, spina bifida occulta, open spinal when only meninges herniating out, meningocele, when spinal cord also herniating out, myelomeningocele. Overall most common neural tube defect is spina bifida occulta, most serious neural tube defect is myelomeningocele. Folic acid dose for primary prevention of neural tube defect 0.4 milligrams per day, and for secondary prevention 4 milligrams per day. This is periconceptual administration of folic acid. When I told you abnormalities in head size, microcephaly, macrocephaly. Microcephaly causes, I told you, torch infections. Most common torch infection is microcephaly, cytomegalovirus. Then hypoxic ischemic encephalopathy, Down syndrome, Edwards syndrome, Cry-du-Chat syndrome, and fetal alcohol syndrome and fetal hydrantoid syndrome. Macrocephaly, hydrocephalus is most important cause. Then other causes of large head are 3 metabolic disorders I told you: Alexander's disease, Canavan's disease, Tay-Sachs disease. Then abnormalities in head shape. I told you, are craniosynostosis. Most common types, scaphocephaly, premature fusion of sagittal sutures, scapho S, sagittal S. Premature fusion of mitopic sutures leads to which type of cephaly? Trigonocephaly. Premature fusion of both coronal sutures, both B, brachycephaly B. So premature fusion of both coronal sutures, brachycephaly. Both coronal sutures B, brachycephaly B. Premature fusion of one coronal suture, anterior plagiocephaly. One lambdoid suture, posterior plagiocephaly. Which are the syndromes which are associated with craniosynostosis? Carpenter syndrome, Klusen syndrome, or Pfeiffer syndrome, and Eppert syndrome. Then I was telling you the most common seizures of childhood are febrile seizures. I told you the criteria for simple and complex febrile seizures. I told you the criteria, which are the type of febrile seizures which can progress to epilepsies. What are the indications of doing a lumbar puncture, and what is the indication of giving prophylaxis? More than equal to 3 episodes in 6 months, more than equal to 4 episodes in 1 year. So I hope till here everything has been very clear to you. We take a break of around 20 minutes here. After 20 minutes break, the next part of neurology, the last part of neurology we'll do, after which we'll come to chapter number 5, which is pediatric renal disorders. So we take a 20 minutes break, and after the break we'll restart. So welcome back, friends. Continuing with neurology now, let us come to the next topic, which is, and we are still doing neurology. So let us come to the next topic, which is the pediatric meningitis. So meningitis in children. Now, I will not go into too much of details about meningitis in children, because meningitis in children is not much different from meningitis that you study in medicine. But there are a few things that you need to know. The first and the most important thing are the causes of meningitis in children. Now, that varies according to the age group of the child, and hence it is very important for you to know the important causes of meningitis across the world also, and in India also. Now, between birth till 2 months, that is in all children who are less than 2 months, worldwide the most common cause of meningitis is group B streptococcus. But in India, group B streptococcus is not that common. So the most common cause of meningitis in the first 2 months of life. So this includes neonates also. So the most important cause of meningitis in the first 2 months, including neonatal meningitis, is E. coli in India. So worldwide, the most common cause is group B streptococcus, but in India, it is E. coli. Other causes of meningitis are Klebsiella, Staphylococcus, and Listeria monocytogenes. So first 2 months, what are the most important causes of meningitis? Group B streptococcus, E. coli, Klebsiella, Staphylococcus, and Listeria. Among these, the most important cause of meningitis in neonates worldwide is group B streptococcus, but the most common cause of meningitis in neonates in India is E. coli. Please remember the general rule: neonatal meningitis in majority of cases is caused by gram-negative bacteria, and E. coli and Klebsiella remain the two very important causes. Now, the important cause of meningitis in India are both E. coli and Klebsiella, but out of the two, probably I would say E. coli is more common in comparison to Klebsiella. Between 2 months to 3 years, Haemophilus influenza is the most common cause of meningitis, followed by Streptococcus pneumonia and meningococcus. So the most common cause of meningitis in the first 2 months is group B Streptococcus, E. coli, Klebsiella, Staphylococcus, and Listeria. This is in the first 2 months. Between 2 months to 3 years of age, the most common cause of meningitis is Haemophilus influenza, Streptococcus pneumonia, and meningococcus. Now, Streptococcus pneumonia used to be a very, very important cause of meningitis, but I think in the current edition of GHAI, they have said that 2 months to 3 years, it is Haemophilus influenza which is the most common. You can check GHAI once. So although Streptococcus pneumonia was the most common cause of meningitis in children between 2 months to 3 years of age, now in GHAI, the current edition, they have written Haemophilus influenza B is the most common. After 2 years, Streptococcus pneumonia and meningococcus are the most common causes of meningitis in children. So if you are asked a question, which is the most common cause of neonatal meningitis, which includes meningitis in the first 2 years of life, first 2 months of life. So you will say worldwide, the most common cause is group B streptococcus, but in India, the most common cause is E. coli. So which is the most common cause of meningitis in India worldwide? Because in India, it is most common cause of neonatal meningitis in India is E. coli, but worldwide, the most common cause of meningitis in neonate is group B streptococcus. As you can see in the first 2 months, apart from group B and streptococcus in E. coli, other important causes are Klebsiella, Staphylococcus, and Listeria. Staphylococcus in particular is a cause of very, very severe meningitis in children. Between 2 months to 3 years of age, then Haemophilus influenza is probably the most common cause. So if now you are asked a question, which is the most common cause of meningitis in children between 2 months to 3 years of age, then your answer will be Haemophilus influenza type B. So it was Streptococcus pneumonia, which was the most common cause in the past, but now in Ghai, I think it is written Haemophilus influenza type B is the most common cause of meningitis in children between 2 months to 3 years of age. But that does not mean Streptococcus pneumonia is not common in this group. Apart from Haemophilus influenza B, Streptococcus pneumonia and meningococcus are also important causes of meningitis between 2 months to 3 years of age. After 2 to 3 years of age, the most common cause of meningitis usually remains Streptococcus pneumonia and meningococcus. So no problems here. First 2 months, worldwide group B Streptococcus, in India E. coli. 2 months to 3 years, most common is Haemophilus influenza, followed by Streptococcus pneumonia and meningococcus. After 2 to 3 years, Streptococcus pneumonia and meningococcus are the most common causes of meningitis in children. Meningitis can lead to different complications. And please remember, overall, the most common complication of meningitis in children is seizures. This is again an FMG question. Which is the most common overall complication of meningitis in children? It is seizures. However, when it comes to specifically Haemophilus influenza meningitis caused by Haemophilus influenza, probably subdural effusions is a very, very important complication of meningitis. And when it comes to Streptococcus pneumonia, deafness is a very important complication. So there are three important complications of meningitis you should be aware of: seizures, then deafness, and then subdural effusion. Please hear carefully what I am saying: seizures, deafness, and subdural effusion. Overall, which is the most common complication of meningitis in children? Overall, the most common complication of meningitis in children is seizures. Second, which is the most common complication of pneumococcal meningitis in children? Streptococcus pneumonia. It is deafness. Sensorineural deafness is very, very common in children who have Streptococcus pneumonia induced meningitis. And if the meningitis is caused by Haemophilus influenza B, subdural effusions are very, very common complications. Sometimes deafness can also. So I hope it is now clear. Overall, most common complication is seizures. Most common complication is Streptococcus pneumonia, deafness, and the most common complication in Haemophilus influenza is subdural effusions, although deafness can occur in Haemophilus influenza meningitis also. That is why when you are treating a meningitis, apart from antibiotics, which are normally given, you often give dexamethasone, a corticosteroid. So IV dexamethasone is often used, it's a corticosteroid, is often used for the first 2 days in treatment. And what is the purpose of giving corticosteroid? It is to reduce the incidence of complications, particularly deafness in children. So when you are managing a case of meningitis, management of meningitis. Third generation cephalosporins are normally given intravenously, are the drug of choice. And for how long they are given? They are given for a total duration of about 7 to 10 days. So it depends. Some children by around 7 days meningitis features can end. Sometimes the antibiotic needs to be given for 8 days, sometimes for 9 days, sometimes for 10 days. So total duration of antibiotic is usually 7 to 10 days. We normally start with the intravenous third generation cephalosporin such as ceftriaxone or cefotaxime. In case, now please carefully listen to what I'm saying. In case response does not occur in the first 48 hours, vancomycin can be added. What is the treatment you start with? The treatment that you start with is a third generation cephalosporin, such as a cefotaxime or ceftriaxone. But in case in 48 hours response does not occur, you have to add a second antibiotic to treatment, which is vancomycin. In addition, intravenous dexamethasone. Dexamethasone is a corticosteroid. Is given for the first 2 days. And what is the purpose of giving dexamethasone? Dexamethasone is responsible for reducing the complications of meningitis, particularly deafness. Because we are worried about deafness, subdural effusions, and seizures being complications of meningitis. So in the first 2 days of treatment, when we have started antibiotics, IV dexamethasone is also given to reduce these complications. So I'll just repeat again. Meningitis, what are the most common causes? The most common causes can be divided into causes in the first 2 months, causes between 2 months to 3 years, and causes after 2 to 3 years of age. In the first 2 months, which includes neonatal meningitis, worldwide the most common cause is group B streptococcus, but in India the most common cause is E. coli. Apart from group B streptococcus and E. coli, other causes of meningitis are Klebsiella, Staphylococcus, and Listeria. Then between 2 months to 3 years of age, the most common cause of meningitis in children is Haemophilus influenza, followed by Streptococcus pneumonia and meningococcus. After 2 to 3 years, the most common cause of meningitis is usually Streptococcus pneumonia and meningitis. So obviously they can give a question to you like this. A 6-month-old child is known to have meningitis, which is the most likely cause. So if it is a 6-month-old child, the child will be in which age group? 2 months to 3 years. A neonate has meningitis, which is likely to be the most common cause. A 5-year-old child has meningitis, which is likely to be the most common cause. So you'll find out the most common cause based upon this table. Which is overall the most common complications of meningitis in children? It is seizures. So children who have meningitis frequently have seizures. Other complications of meningitis, especially very common in children who have Streptococcus pneumonia infection, is deafness. That is why screening for deafness is very important, especially in a young child who has meningitis. And if that meningitis is caused by Streptococcus pneumonia. So screening for deafness is very important before discharge. Another important complication very frequently seen with Haemophilus influenza B is subdural effusions. However, Haemophilus influenza B meningitis not only leads to subdural effusions but can also lead to deafness. When it comes to treatment of meningitis, the third generation cephalosporins are normally given, such as cefotaxime or ceftriaxone. The total duration of treatment is 7 to 10 days. Please write somewhere whenever there is a gram-negative meningitis, for example, a meningitis caused by E. coli or Klebsiella, then a 10 days treatment is not enough. In those cases, a 3 weeks treatment, 21 days of treatment is given. So when is a 3 weeks treatment given? A 3 weeks treatment is given particularly if meningitis is caused by gram-negative bacteria. So I am giving you an example. A 1-month-old child has meningitis. IV ceftriaxone or IV ampicillin is started in this child. How long should treatment be given to this child to attain a complete recovery? So because it is a gram-negative meningitis, say isolated organism is E. coli. So because it is a gram-negative meningitis, the treatment duration will be 3 weeks. Otherwise, in all other cases, the treatment duration is about 7 to 10 days. So which is the only condition in which treatment duration is 3 weeks? It is meningitis caused by gram-negative bacteria. Is there any other treatment which is given apart from this? Yes, IV dexamethasone. It is a corticosteroid. IV dexamethasone is also given, particularly in the first 2 days of treatment. It is usually believed that IV dexamethasone, which is a corticosteroid, reduces the complications of meningitis, particularly deafness. The next disorder we do is cerebral palsy. Cerebral palsy is a non-progressive neuromotor disorder that is seen in children, commonly resulting from injury to the brain very early in life. So what is cerebral palsy? Cerebral palsy is a non-progressive, it's very important to remember, non-progressive, it's not a progressive neurological disorder. It's a non-progressive neurological disorder which occurs because of injury to the brain very early in life. The causes of cerebral palsy are many. Causes of cerebral palsy. Cerebral palsy will occur because of anything which can damage the growth of the brain very early in life. If you remember in my first class, when I was telling you the growth of the brain, I told you the head circumference is 35 centimeters. Please hear carefully. Head circumference is 35 centimeters at birth. If you remember the topic that I discussed in the first class, head circumference is 35 centimeter at birth, and then I told you 20 centimeter increase in head circumference then occurs in 5 years. Out of that 20 centimeter, 12 centimeter increase occurs in the first year only. Remember, 12 centimeter out of 20 centimeter increase occurs in the first year only. So first year of life is a time when the head is growing very, very fast. At this time, any damage which occurs to the brain of the child can lead to a lifelong disability, which is known as cerebral palsy. The causes of cerebral palsy include prematurity. Then it includes hypoxic ischemic encephalopathy, which we discussed in neonatology. It can be a damage to the brain which can occur because of serum bilirubin levels, so kernicterus. It can also occur because of congenital infections, torch infections in children. In addition, a low birth weight can also be an important cause of cerebral palsy. However, out of all of these, which is the most common cause of cerebral palsy in children? It is prematurity. A preterm child is probably at the highest risk of developing a cerebral palsy. And more premature is the child, higher is the risk of developing cerebral palsy. So what are the important causes of cerebral palsy? There are many causes, but the important causes are prematurity, hypoxic ischemic encephalopathy, kernicterus, torch infections, low birth weight, even a meningitis occurring very early in life. Meningitis. Even meningitis occurring with, in short, anything that damages the brain of a child at the time when the brain is growing very rapidly can result in a lifelong disability, which is known as cerebral palsy. The child is known as a spastic child. You must have seen a child like this. And this is a child whose brain has been damaged. And once the brain has been damaged, it is permanently damaged. You can never correct that part of the brain. So therefore, it should always be prevented. The maximum effort should be to prevent any damage to the brain. After 5 years, when the mature head circumference has been achieved, brain stops growing. After that, any damage to the brain is unlikely to result in a cerebral palsy. So cerebral palsy usually occurs due to injury to the brain at the time when the brain is growing very, very fast. Prematurity, low birth weight, hypoxic ischemic encephalopathy, kernicterus, torch infections, neonatal meningitis. Overall, most common type of cerebral palsy is prematurity. So if you are asked a question in your exams, FMG exams, which is the most common cause of cerebral palsy in children, it is prematurity. Okay, how do you classify cerebral palsy? I hope you have all written this. Okay, so how do you classify cerebral palsy? Classification of cerebral palsy. So cerebral palsy is classified based upon which part of the brain is predominantly damaged. So the first type of cerebral palsy, that is probably the most common, is known as spastic cerebral palsy. Spastic cerebral palsy, and usually occurs because of damage to which part of the brain? Usually occurs because of damage to the cerebral cortex. This also happens to be overall the most common type of cerebral palsy. It also happens to be the most common type of cerebral palsy. Now here what happens is the child is having hands or legs which have gone into a spasm. So it is a spastic cerebral palsy in which either one half of the body is spastic, or both the arms, both the legs are spastic, or only the legs are spastic. So spastic cerebral palsy can be divided into three categories. One is a spastic hemiplegia. A spastic hemiplegia, as the name suggests, one half of the body has increased tone. So the arms and the legs have increased tone, but the other half of the body is normally. So spastic hemiplegia, spasticity in one half of the body. And when there is spasticity in one half of the body, it usually is that the arms are affected to a greater extent than the legs. So one half is affected. So arm and leg of one side is affected. But out of the two, it is likely that the arms are affected to a greater extent than the legs. This type of spastic cerebral palsy is known as spastic hemiplegia. The second type of spastic cerebral palsy is when the leg's tone is increased, spastic diplegia. Here what happens is the leg's tone is significantly increased. So now it is not hemiplegia, now it is diplegia. So the arms are relatively less affected in comparison to the legs. Legs are significantly affected, not the arms. I'm not saying arms are normal. Arms are also affected, but the tone of the legs is significantly more in comparison to the arms. This type of spastic cerebral palsy is known as spastic diplegia. Please don't confuse a diplegia from a paraplegia. A paraplegia is when the legs are affected but the arms are absolutely normal. So you should not confuse between diplegia versus paraplegia. Don't confuse. Paraplegia is basically when the legs are affected but the arms are absolutely normal. Diplegia is arms are also affected and legs are also affected, but the legs are affected to a much greater extent in comparison to the arms. So the first type of spastic cerebral palsy is spastic hemiplegia. One half of the body has increased tone, the other half of the body is normal. The second type of spastic cerebral palsy is spastic diplegia. The tone of the legs is significantly increased. Arms are less affected. I'm not saying arms are normal. Arms are less affected. And the third type of cerebral palsy is known as spastic quadriplegia. As will be understandable, this is the type of cerebral palsy in which all the four limbs have increased tone. Quadriplegia, that means the tone of the arms is also increased and the tone of the legs is also increased. This is known as spastic quadriplegia. So the first type of spastic cerebral palsy is spastic hemiplegia. The second type of spastic cerebral palsy is spastic diplegia, and the third type of spastic cerebral palsy is spastic quadriplegia. Hemiplegia, one half of the body has increased tone. Diplegia, both the legs have more tone in comparison to the arms. And quadriplegia, the tone of both the arms and both the legs are affected. The one that is most commonly seen in India possibly is a spastic quadriplegia. So which type of cerebral palsy is usually most commonly seen in India? Most commonly seen in India possibly is spastic quadriplegia. There has been again a lot of debate on this, and some books mention spastic diplegia, some books mention spastic quadriplegia. But I think you can remember spastic quadriplegia is the type of cerebral palsy that possibly is the most commonly seen in India. Overall, which is the most common type of cerebral palsy? I have written it is spastic cerebral palsy. How is spastic cerebral palsy subclassified? One half of the body has increased tone, hemiplegia. Both the legs have more tone in comparison to the arms, diplegia, and the arms and the legs have equally increased tone, it is quadriplegia. The one that is most commonly seen in India is possibly spastic quadriplegia. Now, just pay attention for 2 minutes. Please put your pen down and just hear carefully what I am saying. Let me go back to yesterday's class when I was doing hypoxic ischemic encephalopathy. If you want to open up your notes, you can open up your notes also. When I was talking about neonatology and I was talking about birth asphyxia and I was talking about hypoxic ischemic encephalopathy. If you want to open up your notes, please open up your notes. Otherwise, I expect you should be able to remember that. I told you whenever hypoxic ischemic encephalopathy occurs, the type of damage that occurs to the brain can be different in a term child and in a preterm child. If you remember, I told you in a term child there is selective neuronal necrosis, which can occur either in the watershed areas of the brain, resulting in watershed infarcts, or it can occur in the basal ganglia, which can result in status marmoratus, or it can be damage to the sulcis with the gyres remain intact, which is known as olighyrias or mushroom shaped gyres. Remember? Okay. In preterms, I told you, whenever there is hypoxic ischemic encephalopathy, the most common ischemic brain injury which occurs in preterms is a periventricular leukomalacia. Now comes the most important question. Periventricular leukomalacia. Now this is a damage inside the brain. Periventricular leukomalacia, when it occurs in premature infants, what type of cerebral palsy does it lead to? It leads to a spastic diplegia. So this is a consequence of periventricular leukomalacia. So it is the most common type of cerebral palsy which is seen in preterm infants, because periventricular leukomalacia is seen in preterms. So the most common type of cerebral palsy that is seen in preterm infants, because preterm infants, they have periventricular leukomalacia, and periventricular leukomalacia frequently leads to a spastic diplegia. So which is the type of cerebral palsy which is commonly a result of periventricular leukomalacia and is the most common type of cerebral palsy seen in preterm infants? It is a spastic diplegia. So I hope you have understood this very well. I'll repeat this again. Spastic cerebral palsy is overall the most common type of cerebral palsy in which the tone is increased. Tone of the extremities is increased. Spastic cerebral palsy is overall the most common. Spastic cerebral palsy is further subclassified into three types: spastic hemiplegia, spastic diplegia, and spastic quadriplegia. Spastic hemiplegia is when one half of the body the tone is increased, the other half of the body the tone is normal. Now in a spastic hemiplegia, the arms and the leg on one side have increased tone, but it is the arms which are affected to a greater extent than the legs. Then we come to spastic diplegia. In a spastic diplegia, it is the tone of the legs which is increased to a greater extent in comparison to the arms. I told you, don't confuse a diplegia with a paraplegia. In a paraplegia, usually the arms are absolutely normal. It is the legs which are affected. But in a diplegia, as I just now told you, arms are also affected, but arms are affected to a greater extent, arms are affected to a lesser extent in comparison to the legs. So the legs are the ones which are affected to a greater extent. So when these children start to walk, they start to walk on their toes because the tone of the legs is significantly increased. So they cannot walk on their foot. They start to walk on their toes. So toe walking. So when they are walking, it is toe walking. So the mother says, my child is walking on his toes. Any child, remember when I told you milestones, I told you when does a child starts to walk? Holding on to a support, he probably will be walking at 10 to 11 months. So a mother of a 12-month-old child comes to me and says, doctor, my child has started to walk.